Hello, everyone, and welcome to our video on Down syndrome. If a fertilized egg has 3 copies of one of the chromosomes, that's called a trisomy, and most trisomies are not compatible with life and will lead to a miscarriage. However, there are a couple of trisomy disorders where the baby can potentially be carried to term and sometimes survive after birth. And the 3 main disorders for which that's the case are Down syndrome, which is trisomy 21, Edwards syndrome, which is trisomy 18, and Patau syndrome, which is trisomy 13. We'll talk about these other 2 in another video, but in this video, we're going to focus on Down syndrome, which is the most common trisomy disorder and something that you're likely to see in clinical practice. Down syndrome is the most common live-born chromosome abnormality, and the word live-born is important because among fertilized eggs in which there is a miscarriage, there are many other chromosomal abnormalities which can be found. Down syndrome is also the most common form of intellectual disability. Intellectual disability was formerly called mental retardation, and Down syndrome is the most common cause of this among children. Other key features of Down syndrome, which we'll go through on the next few slides, include what's known as dysmorphic features. These are basically abnormal features of the face and extremities. This includes the face, hands, and also the stature of the child with Down syndrome. Congenital malformations are also common in Down syndrome. We'll talk about those. These include the heart and the GI tract. People with Down syndrome develop early Alzheimer's disease, and they also have an increased risk of malignancy. And you should be aware that the clinical phenotype of Down syndrome is highly variable. There's a range of features from mild to severe. Some people with Down syndrome are highly functional, and other patients are severely limited. Let's start by talking about the dysmorphic features of Down syndrome. Children with Down syndrome are often described as having a flat facial profile. If you look at this picture on the screen here, you can see that this baby's face just looks relatively flat relative to normal. In addition, they have a flat nasal bridge. So this is the nasal bridge. It's the portion of the nose between the eyes. And if you feel your own, it's probably kind of risen up a little bit. It's flat in babies with Down syndrome. Down syndrome children also have low set small ears, like this drawing on the screen, and a short neck. And then finally, they have what's described as brachycephaly. This is the posterior skull being flat. So you can't see that in this picture of this child. But if you could look at this child in profile, you'd see the front of the face is rounded, but the back is relatively flat. You can Google and find pictures of this, and that's brachycephaly, which is common in Down syndrome. There are several classic abnormalities of the eyes that can be seen in children with Down syndrome. The first one are prominent epicanthal folds. So the epicanthal folds are the skin of the upper eyelid that covers the inner portion of the eye. I'm marking my pen with it on this zoomed in image on the screen here, and these are prominent in children who have Down syndrome. Also in children with Down syndrome, the palpebral fissures are up slanting. The palpebral fissures are the separation between the upper and lower eyelids. Normally they are horizontal. However, as you can see in the zoomed in picture, the outer corner is higher than the inner corner, and therefore they are up slanting in this picture of a person with Down syndrome. Brush field spots are another characteristic finding of the eyes in Down syndrome. These are white spots on the iris. This baby has it in this picture here. I've zoomed in on the right side of the screen so you can see the white spots on the iris. Those are brush field spots. Children with Down syndrome often have short, broad hands. And then there are 2 classic findings in the hands and the feet that you should know about. The first one is called a transverse palmar crease. This is a crease that goes across the palm. I'm circling one on the right side of the screen with my pen. This is a classic finding in children with Down syndrome. In the feet, the classic finding is a sandal gap. This is a space between the first and second toes, as shown in this picture here. This is the separation that would occur if you were wearing sandals. That's how it gets its name. Other physical features you should be aware about are hypotonia. So the muscle tone is often decreased, and this can often be identified shortly after birth in children with Down syndrome. And then as children with Down syndrome grow up, they often have short stature and are short for their age. Intellectual disability is another hallmark of Down syndrome. Almost all patients are affected, although there's a wide range of cognitive impairment. A normal IQ is 100 or greater. Children with mild Down syndrome can have an IQ of about 50 to 70. Children with a more severe case can have an IQ of 20 to 35. And this will obviously have a big effect on the type of services these children need as they grow up. Congenital heart disease occurs in 50% of patients who have Down syndrome. Most commonly, these are defects that result from abnormal formation of the endocardial cushions. In the cardiology section, in the embryology video, I talk about the endocardial cushions in detail. They are embryologic structures that form the septum between the two atria and the two ventricles. If you look at this picture on the screen here, this is the right atrium here and the left atrium here. We have the left ventricle here and the right ventricle here. The endocardial cushions form this section of the heart right in here. So if they are abnormal, you can get an ASD at the bottom of the interatrial septum. That's called a primum ASD. You can also develop a VSD right here. And in addition, the endocardial cushions contribute to the formation of the mitral valve. So if there's an endocardial cushion defect, you can potentially develop mitral regurgitation. I've summarized that here. The endocardial cushions involve the atrioventricular septum. They form the base of the interatrial septum and the upper interventricular septum. So common defects that can be seen in Down syndrome, as I mentioned before, are defects that involve the atrioventricular septum that comes from the endocardial cushions. So this includes a primum ASD or a VSD. And remember that a VSD can cause a holosystolic murmur. And this is high yield for you to remember, especially for the boards. If they describe a baby with a holosystolic murmur, they may be describing a VSD that can be seen in Down syndrome. Gastrointestinal anomalies are also common in children with Down syndrome. They occur in about 5% of patients. The most common congenital anomaly is duodenal atresia or stenosis. I talk about this in more detail in the GI section. In addition, children with Down syndrome are more likely to develop Hirschsprung disease than the general population. Most patients with Down syndrome will eventually develop Alzheimer's disease. And in addition to being common, it occurs earlier in patients with Down syndrome than in the general population. In patients with Down syndrome, the average age of onset of Alzheimer's disease is in the 50s. In the neurology section, I discussed the pathophysiology of Alzheimer's in detail, but I just want to mention that amyloid precursor protein, which is a very important pathologic element of Alzheimer's disease, is found on chromosome 21, and patients with Down syndrome have 3 copies of chromosome 21. Amyloid precursor protein breaks down to form beta amyloid, and amyloid plaques are a pathologic element of Alzheimer's disease. Children with Down syndrome also have an increased risk of malignancy, especially leukemia. The lifetime risk of leukemia is about 1 to 1.5%. It often occurs in childhood. Children with Down syndrome can develop acute lymphoblastic leukemia. The risk is 10 to 20 times higher in Down syndrome children than in the general population. They can also develop acute myeloid leukemia, and they develop a very unique subtype. It's called the M7 subtype. It is a megakaryoblastic leukemia made up of leukemia cells that resemble megakaryocytes. Let's talk about the genetic of Down syndrome. In other words, why do babies with Down syndrome develop with 3 copies of chromosome 21? Well, the most common reason is a meiotic non-disjunction, and I talk about this in detail in the video on meiosis. When this happens, the baby receives 2 chromosomes from one parent and 1 from the other. This is the most common cause of Down syndrome. It's responsible for 95% of cases, and in 90% of cases, the error is in meiosis 1. In addition, the extra chromosome comes from the mother in 90% of cases. And for this reason, Down syndrome is associated with advanced maternal age. In the video on meiosis, I discuss how that process is protracted in females and often frozen in place for many years of time. For this reason, the more advanced the mother's age, the longer it takes for meiosis to complete in the egg, and therefore the greater risk that there can be a problem in meiosis that leads to trisomy 21. In cases that are not associated with meiotic non-disjunction, one of the potential causes is a Robertsonian translocation. I also talk about this in the video on meiosis. This is responsible for 2 to 3% of cases of Down syndrome. In a Robertsonian translocation, chromosome 21 is fused with another chromosome, most commonly chromosome 14 or 10. And because the two chromosomes are fused, two copies of chromosome 21 can be passed to the fetus from one parent. Now, this problem is different from meiotic non-disjunction in that it is not associated with advanced maternal age. What's unique about a Robertsonian translocation is that the fused chromosome can be passed through families, and therefore there is a recurrence risk for Down syndrome within families. So this is especially important for a board question. If you see a description of a child born with Down syndrome, and there are a number of family members in the extended family who also have Down syndrome, you should think about the possibility that a Robertsonian translocation may be the underlying genetic cause of Down syndrome, and they're on to 10. And because the two chromosomes are fused, two copies of chromosome 21 can be passed to the fetus from one parent. Now, this problem is different from meiotic non-disjunction in that it is not associated with advanced maternal age. What's unique about a Robertsonian translocation is that the fused chromosome can be passed through families, and therefore there is a recurrence risk for Down syndrome within families. So this is especially important for a board question. If you see a description of a child born with Down syndrome, and there are a number of family members in the extended family who also have Down syndrome, you should think about the possibility that a Robertsonian translocation may be the underlying genetic cause of Down syndrome in that family. Another rare cause of Down syndrome is a mitotic error. So this is an error in mitosis, not meiosis. In this situation, the egg is fertilized normally with two copies of chromosome 21. However, in early development, during mitosis, a cell develops which has three copies of chromosome 21, and it will continue to replicate, making more cells with three copies of chromosome 21. This will result in somatic mosaicism. Mosaicism is when some cells have different numbers of copies of chromosomes compared to others. So in this situation, when there's a mitotic error, the child will have some cells with three copies of chromosome 21 and other cells will be normal. This can lead to milder features of Down syndrome, as you can imagine, because some cells in the body have the normal numbers of chromosomes. And this is also not associated with advanced maternal age. This is a sporadic error. I'll finish this module by talking about prenatal screening. In other words, ways to screen pregnant women for the possibility that their baby may have Down syndrome. The definitive test is to obtain a sample of the fetal cells and do a fetal karyotype, which means determining the number of chromosomes in the baby. The problem with this screening test is that it is invasive and carries risk. So you only want to do it when there is a high probability that the baby may have Down syndrome. There are two ways a fetal karyotype is commonly done. One is called chorionic villus sampling. This requires taking a sample of the placental tissue. The other way is an amniocentesis, which involves inserting a needle into the amniotic cavity and taking a sample of the fluid, which contains some cells from the baby. So when you do a karyotype, you create a karyogram, which is a picture of the chromosomes from one of the cells. And this is a normal karyogram. You can see that there are two copies of all the chromosomes. And here is a karyogram from a baby that has a trisomy. You can see that for one of the chromosomes,
What? Ain't no way, bro.
here there are three copies, and that is abnormal. So because karyotyping requires an invasive test, there are several non-invasive tests, which are usually done to determine the likelihood that the baby may have Down syndrome. And only in cases where the likelihood is high is the non-invasive test followed up with a karyotype. The two non-invasive tests that are commonly used are an ultrasound of the baby and maternal blood testing or serum testing. In the first trimester, there are several findings on fetal ultrasound that are suggestive of Down syndrome. The first one is the presence of small, poorly formed nasal bones. We talked before about how children with Down syndrome have a flat profile and a flat nasal bridge, and you can see some of those features on a fetal ultrasound. The second characteristic finding is nuchal translucency. This is fluid under the back of the neck. This is a picture showing nuchal translucency on the screen. This is the back of the neck here, and there's this black space that represents fluid. And if that is seen in a first trimester ultrasound, that is suggestive of Down syndrome. In addition, and you can see Down syndrome, tests that are commonly used are an ultrasound of small, poorly formed nasal bones. We talked before about how children with Down syndrome have a flat profile and a flat nasal bridge, and you can see some of those features on a fetal ultrasound. The second characteristic finding is nuchal translucency. This is fluid under the back of the neck. This is a picture showing nuchal translucency on the screen. This is the back of the neck here, and there's this black space that represents fluid. And if that is seen in a first trimester ultrasound, that is suggestive of Down syndrome. In addition to fetal ultrasound, there are several pregnancy-associated substances whose level can be measured in the maternal blood. And if the levels are high or low compared to normal, this can suggest Down syndrome is present in the fetus. There are different substances that are associated with Down syndrome in the first trimester and the second trimester. In the first trimester, the two substances whose levels can be measured to screen for Down syndrome are the level of pregnancy-associated plasma protein A, or PAP-A, and the free or total level of beta-HCG. PAP-A is a glycoprotein produced by the placenta, and lower levels compared to normal are found in pregnancies with fetal Down syndrome. Beta-HCG, as you may know, is a hormone produced by the placenta, and levels are higher in pregnancies that are associated with fetal Down syndrome. In the second trimester, there are 4 substances that can be measured in the maternal blood to screen for Down syndrome. This is often called the quad screen. The first two are alpha-fetoprotein and estriol, or it's sometimes called UE3. Levels of these two substances are reduced in pregnancies with fetal Down syndrome. AFP is a protein produced by the yolk sac and liver, and estriol is an estrogen. And just a note here, increased levels of AFP are associated with neural tube defects, which I talk about in the neurology section. So this is a very useful screening marker in pregnancy. Low levels suggest Down syndrome, high levels suggest a neural tube defect. The other two components of the quad screen are beta-HCG, just like is used in the first trimester, and inhibin A. Levels of these two substances are increased in pregnancy with fetal Down syndrome in the second trimester. Inhibin A is synthesized by the placenta, and in pregnancies associated with Down syndrome, more of that substance is secreted, and therefore more is found in the maternal blood. And that concludes our module on Down syndrome. Hello, everyone, and welcome to our module on trisomy. Trisomy disorders are disorders that occur when a baby is born with 3 copies of one of the chromosomes instead of 2. The most common trisomy disorder is Down syndrome, which is trisomy 21, which I talk about in a separate module. In this module, we'll talk about 2 less common trisomy disorders, Edwards syndrome, which is trisomy 18, and Patau syndrome, which is trisomy 13. All of the trisomy disorders on the last slide, Down syndrome, Edwards syndrome, and Patau syndrome, share some common features which can help you to remember them as a medical student. First of all, they are all associated with advanced maternal age, and they are also all most commonly due to meiotic non-disjunction, which I discuss in more detail in the Down syndrome video and the video on meiosis. In addition, all 3 of these trisomy disorders share common features, including intellectual disability, physical deformities, and congenital heart defects. And an easy way to remember Edwards syndrome and Patau syndrome that I've always found helpful is to just think of them as more severe versions of Down syndrome. Children with Down syndrome can be functional and sometimes can live long lives. Children with Edwards syndrome and Patau syndrome are more severely disabled and often die in utero or early in life. We'll start by talking about Edwards syndrome, which is trisomy 18. This is the second most common trisomy in live births. Down syndrome, or chromosome 21 trisomy, is the most common. Children born with Edwards syndrome have severe intellectual disability, and this often occurs in female babies. There's a 3-to-1 female to male ratio. Babies with Edwards syndrome have poor intro. We'll start by talking about Edwards syndrome, which is trisomy 18. This is the second most common trisomy in live births. Down syndrome or chromosome 21 trisomy is the most common. Children born with Edwards syndrome have severe intellectual disability, and this often occurs in female babies. There's a 3-to-1 female to male ratio. Baby trisomy is the most common. Children born with Edwards syndrome have severe intellectual disability, and this often occurs in female babies. There's a 3-to-1 female to male ratio. Babies with Edwards syndrome have poor intrauterine growth. They are often born with a low birth weight. One of the characteristic features is a very abnormally shaped head. It's often very small, and the back of the head protrudes out. This is described as having a prominent occiput. You can Google this and see pictures of baby with Edwards syndrome. Their head is very misshapen. The ears are low set, just like in children with Down syndrome, and they often have a small jaw and mouth. And then two characteristic features that are often helpful, especially in board questions, are that children with Edwards syndrome often have clenched fists with overlapping fingers, like as is shown in this picture on the screen. In addition, they often have curved feet that are described as rocker bottom feet. Just like Down syndrome, Edwards syndrome is associated with congenital heart disease and gastrointestinal defects. Congenital heart disease occurs in about 50% of babies. It's often ventricular septal defects or PDAs. Gastrointestinal defects are more common in Edwards syndrome than in Down syndrome. In Down syndrome, they only occur in a few percent of cases. In Edwards syndrome, 75% of babies have a gastrointestinal defect. It's often a Meckel's diverticulum, but can also be malrotation or an omphalocele. And I talk about all of these congenital GI defects in the gastroenterology section. As I said before, an easy way to remember Edwards syndrome is to think of it as a more severe form of Down syndrome. Children with Down syndrome often grow into adulthood. However, most babies with Edwards syndrome die in utero, and 50% of affected infants die in the first 2 weeks of life, and only a few percent survive the first year of life. Many cases of Edwards syndrome are often diagnosed by fetal ultrasound. These babies have so many physical and congenital abnormalities that you can often identify them in the womb. You may see limb deformities, you may see congenital heart defects, you may see that the skull is misshapen. If the case is not diagnosed by fetal ultrasound, there is maternal blood testing that can be used to suggest the diagnosis, similar to the way it is used in Down syndrome. I talk about this in more detail in the video on Down syndrome, but there are first trimester blood tests that can be done in the mother to determine the likelihood that the baby has Edwards syndrome. So the two blood tests used in the first trimester for Down and Edwards syndrome are PAP-A and beta-HCG. In the Down syndrome video, I talked about how levels of PAP-A are lower than normal in pregnancies associated with Down syndrome, and beta-HCG levels are higher than normal in pregnancies associated with Down syndrome. In pregnancies associated with Edwards syndrome, both levels are low, and in fact, it's very easy to remember the screening results you would expect in Edwards syndrome because they are all lower than normal. In the second trimester, there is a screening test for Down syndrome called the quad screen. This test involves measurement of the serum levels of 4 markers of Down syndrome in the mother's blood. And those 4 markers are AFP, estriol, beta-HCG, and inhibin A. These 4 markers in the quad screen can also be suggestive of Edwards syndrome. In Down syndrome, the first 2, AFP and estriol, are typically lower than normal, but the last 2, beta-HCG and inhibin A, usually have levels in the mother's serum that are higher than normal. In Edwards syndrome, the levels of all 4 markers are usually lower than normal. Moving on, let's talk about Patau syndrome, which is trisomy 13. This is much more rare than Down syndrome or Edwards syndrome. You can think of it as a much more severe syndrome than either Down syndrome or Edwards syndrome. Babies with trisomy 13 have severe intellectual disability. They have severe structural malformations, and it's usually detected by fetal ultrasound in more than 90% of cases because the babies are so abnormal when ultrasound pictures are obtained. Some of the key features I've listed on this slide: the eyes are often abnormal. These babies can have microphthalmia, which is abnormally small eyes. They can also sometimes have anophthalmia, which is absence of one or both eyes. They often have a cleft lip or palate. And another characteristic finding is called post-axial polydactylity. So polydactylity is an extra finger or toe, and post-axial means the extra digit is away from the midline. So in other words, in the hand, it's on the ulnar side. Shown on the screen is pre-axial polydactylity on the top. That's where the extra finger is on the thumb side. The bottom of the screen is post-axial. That's where the extra digit is on the ulnar side of the hand. You can also see extra digits in the feet. These babies often have holoprosencephaly. I discussed this in the embryology video in the neurology section. This is a central nervous system malformation where there is failure of cleavage of the prosencephalon. This leads to left and right hemispheres of the brain that fail to separate. It can result in an alobar brain where there are no apparent lobes of the brain present. Congenital heart disease is very common in trisomy 13, seen in 80% of cases. It can include ventricular septal defects, PDAs, and atrial septal defects, among many other abnormalities. As I said before, this is a very severe chromosomal anomaly. Most cases die in utero. The median survival after birth is 7 days, and 91% of babies with trisomy 13 die within the first year of life. And I mentioned this before, but usually trisomy 13 is diagnosed by fetal ultrasound. If first trimester maternal serum screening is done, the results will be abnormal in a similar manner to the way they are abnormal in Edwards syndrome. Both Edwards syndrome and Patau syndrome give levels in the maternal serum of PAP-A and beta-HCG in the first trimester that are lower than normal. This is in contrast to Down syndrome, where the PAP-A level can be lower than normal, but the beta-HCG level is higher than normal. And that concludes our video on trisomies.
I've studied about this before.
Hi, everybody, and welcome to our module on muscular dystrophy. The muscular dystrophies are a group of genetic disorders. There are more than 30 different types that have been described. They all result from defects in genes that code for proteins important for muscle function, and therefore the main symptom of all of these disorders is progressive muscle weakness. Most of the muscular dystrophies are very rare. I've listed on this slide the 3 variants of muscular dystrophy that you should know for the USMLE Step 1 exam. The first one is Duchenne muscular dystrophy. This is the most common variant. The second one is Becker muscular dystrophy. This is a milder version of Duchenne, but it shares many genetic features with Duchenne, and for that reason, these two are often discussed together. And then the third one is a rare type of muscular dystrophy called myotonic muscular dystrophy. But the reason you should know this one for the Step 1 exam is because it is an example of a trinucleotide repeat disorder. And I won't discuss it in this video, but I do discuss it in detail in the video on trinucleotide repeat disorders. So like I said before, Duchenne and Becker muscular dystrophy are often discussed together. One of the reasons for this is that they're both X-linked. In fact, they're often called the X-linked muscular dystrophies. In addition, they both involve a gene called the DMD gene, and they both involve a protein called the dystrophin protein. And you shouldn't confuse either of these muscular dystrophies with myotonic dystrophy. That disorder has a different gene, a different protein, and it is not X-linked, it is autosomal dominant. So we'll start by talking about Duchenne muscular dystrophy, which is the most common form of muscular dystrophy. It's an X-linked recessive disorder, and it has all the usual features of X-linked recessive disorders that I discussed in the video on pedigree. So all male carriers are affected. A third of cases are due to new mutations in the fertilized egg. In other words, there is no parental carrier that passes on a mutated X gene. In 2/3 of cases, the X gene that is abnormal in the son is inherited from a carrier mother. The gene that is abnormal in Duchenne muscular dystrophy, on the video on pedic dystrophy, which is the most common form of muscular dystrophy, it's an X-linked recessive disorder, and it has all the usual features of X-linked recessive disorders that I discussed in the video on pedigree. So all male carriers are affected. A third of cases are due to new mutations in the fertilized egg. In other words, there is no parental carrier that passes on a mutated X gene. In 2/3 of cases, the X gene that is abnormal in the son is inherited from a carrier mother. The gene that is abnormal in Duchenne muscular dystrophy is the DMD gene. DMD stands for Duchenne muscular dystrophy. And this gene is famous for its massive size. It's 2,300 kilobases in size. It takes up 1.5% of the X chromosome. It is among the largest known genes. And because it is so large, there are lots and lots of nucleotides that have to be replicated to copy this gene, and therefore there is a high chance that a mutation will occur. And this gene codes for a protein called dystrophin, and that's what's abnormal in Duchenne muscular dystrophy. Dystrophin is a protein that's important for maintaining muscle membranes. It connects intracellular actin proteins to transmembrane proteins. Specifically, it connects actin to proteins called alpha and beta dystroglycan in the membrane. And these two proteins in turn are connected to the extracellular matrix to a protein called laminin. So in this way, dystrophin plays a role in linking actin inside the muscle cell to proteins in the membrane and outside the cell. And that's what's abnormal in Duchenne muscular dystrophy. Dystrophin is a protein that's important for maintaining muscle membranes. It connects intracellular actin proteins to transmembrane proteins. Specifically, it connects actin to proteins called alpha and beta dystroglycan in the membrane. And these two proteins in turn are connected to the extracellular matrix to a protein called laminin. So in this way, dystrophin plays a role in linking actin inside the muscle cell to proteins in the membrane and outside the cell. And I've drawn a picture of this at the bottom of the screen to help you understand better. We have actin protein, which is connected via dystrophin to dystroglycan in the cell membrane. And in turn, alpha and beta dystroglycan are connected to extracellular matrix proteins like laminin. Dystrophin is important in skeletal muscle, and that results in many of the muscle symptoms of muscular dystrophy. However, it's also found in cardiac and smooth muscle and also in some brain neurons. And as we will see, the fact that it's found in cardiac muscle is important because many patients with muscular dystrophy develop heart failure and cardiac complications. One of the most important things for you to understand for the Step 1 exam is what I've listed on this slide about the dystrophin gene mutations related to Duchenne and Becker muscular dystrophy. Most of the mutations in both of these disorders are deletions. However, in Duchenne muscular dystrophy, the deletion results in a frame shift mutation. In Becker muscular dystrophy, the deletion results in a non-frame shift mutation. I discussed frame shift mutations in detail in the video on DNA mutations, but by way of brief review, in Duchenne muscular dystrophy, the frame shift mutation results in a disruption of the reading frame. This leads to encountering an early stop codon, and thus children born with Duchenne muscular dystrophy have a truncated or absent dystrophin protein in their bodies. In contrast, children born with Becker muscular dystrophy have a non-frame shift mutation. Thus, they typically have some functioning protein, and therefore this tends to be a less severe disorder. So even though both disorders involve deletions of the same gene, what distinguishes them and why one form is more severe than the other has to do with whether or not the deletion is a frame shift mutation. Just to make this very clear, let's look at the drawing I've made on this slide. Under normal circumstances, the dystrophin gene has a series of codons that I've numbered 1, 2, 3, 4, and 5, and these lead to synthesis of a normal dystrophin protein. In a child born with Duchenne muscular dystrophy, the dystrophin gene has a deletion that occurs after codon 2, and in this case, it is a frame shift mutation, and therefore none of the normal codons after codon 2 are encountered. This leads to either no synthesis of dystrophin protein or a very truncated protein. In contrast, in children with Becker mutation, the dystrophin gene has a non-frame shift mutation. In this example, I've shown a mutation that leads to loss of codon 3. Thus, what you get is an abnormal protein that's missing some of the amino acids, but it still has many of them intact because the mutation did not shift the reading frame. Therefore, Becker tends to be a less severe disorder, even though it involves the same gene and the same protein. When there is loss of dystrophin protein, this leads to myonecrosis. This means that enzymes found inside of muscles can spill into the blood and be detected by blood test. So creatine kinase elevation in the blood is common in the early stages of Duchenne muscular dystrophy. It's released from diseased muscle. Other muscle enzymes can also be elevated in the blood, including aldolase, AST, and ALT. When children initially present with this disorder, the proximal muscles are typically affected first before the distal limb muscles. In addition, the lower limbs are affected before the upper extremities. This means that affected children will have difficulties with activities that involve the lower extremities, things like running, jumping, and climbing stairs. A classic sign of Duchenne muscular dystrophy is when children use their hands to push themselves up from a chair because their lower extremities are so weak. This is called Gower's sign. In addition, they are classically described as having a waddling gait. Basically, they are using the lower parts of their legs to waddle because the upper parts of their legs have become weak. And then finally, the muscle eventually becomes replaced with fat and connective tissue, and this can result in apparent enlargement of the calf. This is called pseudohypertrophy. Many children with Duchenne muscular dystrophy eventually develop a cardiomyopathy. That's why I take care of a few children with this problem. They will develop a depressed left ventricular ejection fraction and systolic heart failure, and they can have myocardial fibrosis seen on biopsy. They can also develop conduction abnormalities, including AV block and arrhythmias. The classic finding on a muscle biopsy, which is rarely done in the modern era, is degeneration of muscle fibers and replacement of muscle by fat and connective tissue. This is an example of what a biopsy slide can look like here. The muscle fibers have been replaced with these clear spaces, and that represents fat. A Western blot test used to be done for diagnosis, but this has been replaced by genetic testing. I talk about Western blot in the video on blotting, but it is a technique that's used to detect proteins. In a Western blot in a patient who has Duchenne muscular dystrophy, there's usually absence of the dystrophin protein. In a patient who has Becker, there's usually an altered dystrophin protein. So if you look at this picture on the right side of the screen, a normal patient is in the middle, and that patient has a band about this far down the gel. A patient with Becker muscular dystrophy also has a band on the gel, but it's at a different location, and that's because the protein has been altered by a non-frame shift mutation. In the patient with Duchenne muscular dystrophy, there's no functioning dystrophin protein, and therefore there's no band seen on the gel. In the modern era, the diagnosis is usually made with genetic testing, usually with variations of the polymerase chain reaction test. This test can identify the most common Duchenne muscular dystrophy gene abnormalities. Basically, it turns out that most children with this disorder have one of a small number of typical deletions. So PCR can be used to test for those deletions, and if one of them is found, then the diagnosis is made. I'll finish by talking about Becker muscular dystrophy. It is also an X-linked recessive disorder, just like Duchenne. In Becker muscular dystrophy, 90% of cases are inherited from carrier mothers. The reason for this is because this is a less severe disease, so more males live to pass on the gene to female offspring, and thus there are more female carriers of this abnormality. In terms of symptoms, this is basically a milder form of muscular dystrophy. It has a later age of onset. Usually children are older. Some patients remain ambulatory during their entire lives, and patients often survive into their 30s or beyond with Becker muscular dystrophy. And that concludes our video on muscular dystrophy. Hello, everyone, and welcome to our module on trinucleotide repeat disorders. Trinucleotide repeat disorders are genetic disorders that occur in genes with repeated trinucleotide units. So, for example, some genes contain the nucleotide CAG repeated over and over again. This is the type of gene where one of these disorders can occur. Most of them involve the central nervous system in one manner or another, and we'll talk about all the examples listed on this slide in this video, including Fragile X syndrome, Friedreich's ataxia, Huntington's disease, and myotonic dystrophy. The genes involved in all of these disorders share some common features. For all of these genes, there is a wild type or normal allele that is found in most individuals. This allele is polymorphic, meaning that it has many forms, and those many forms include a variable number of repeats from person to person. However, overall, even though normal individuals may vary in the number of repeats found within their gene, the overall number of repeats is relatively low. In the disease version or abnormal version of the allele, this is what is found in affected individuals, and there is an increased or expanded number of repeats beyond the normal range, and this is what leads to disease. And the reason that these sections of DNA have varying numbers of trinucleotide repeats is probably related to slipped DNA mispairing. I talk about this in the video on DNA mutations, but this can occur in sections of our genome where there are repeated units and DNA increased or expanded number of repeats beyond the normal range, and this is what leads to disease. Version or abnormal version of the allele, this is what is found in affected individuals, and there is an increased or expanded number of repeats beyond the normal range, and this is what leads to disease. And the reason that these sections of DNA have varying numbers of trinucleotide repeats is probably related to slipped DNA mispairing. I talk about this in the video on DNA mutations, but this can occur in sections of our genome where there are repeated units, and DNA polymerase gets confused when copying the genome, and it makes fewer or additional copies of that trinucleotide repeat. In all of the trinucleotide repeat disorders, the disease gene demonstrates what's known as unstable repeat expansions. What this means is that in addition to the disease gene having more repeats than in normal individuals, the number of repeats may also increase in the offspring, such that from one generation to the next, there are more repeats in the disease gene. And the key point here is that this makes these trinucleotide repeat disorders unusual in that the genetic abnormality may change over time. We like to think of mutations as going along from one generation to the next and being the same mutation. That is not the case in these disorders. With each additional generation, you may see more repeats in the disease gene, and that's called unstable repeat expansions. Because of these unstable repeat expansions, a phenomenon may occur called anticipation. This is where the disease severity worsens in subsequent generations with earlier onset in subsequent generations and sometimes more severe disease. And this is because in additional generations, there are more repeats accumulating in the abnormal gene. The first trinucleotide repeat disorder we'll discuss is Fragile X syndrome. This is an X-linked dominant disorder that results from an abnormal FMR1 gene. FMR1 stands for Fragile X mental retardation 1 gene. It is a gene found on the long arm of the X chromosome. Most commonly, the abnormality in the FMR1 gene is an increase in CGG repeats. Normal individuals have less than 55 repeats in their FMR1 gene. In individuals with the full mutation leading to Fragile X syndrome, they have greater than 200 repeats. And when there are this many repeats in the FMR1 gene, that leads to DNA methylation of the FMR1 gene. I talk about DNA methylation in the video in the biochemistry section on DNA structure. It is a mechanism by which genes can be silenced. And when the FMR1 gene becomes methylated, this leads to silencing of the gene, and therefore it doesn't function normally. Fragile X syndrome is more severe among males. Even though it is X dominant, because males have only one copy of the X chromosome, they have absence of a normal copy of the X chromosome, and that leads to a more severe syndrome. Fragile X is the second most common genetic cause of intellectual disability. Down syndrome is the most common. An easy way to remember the features of Fragile X syndrome is to just think of it as a Down syndrome variant. Children with the Fragile X syndrome can also have anxiety and ADHD. They often have features of autism. They have a characteristic facial appearance with a long, narrow face, large ears, and a large jaw. This is a picture of a child with Fragile X syndrome shown on the screen here. And then finally, a classic feature of Fragile X syndrome is large testicles. This is referred to as macroorchidism. The next trinucleotide repeat disorder we'll discuss is Friedreich's ataxia. This is a hereditary ataxia disorder, and I discuss the clinical symptoms in more detail in the neurology video on the cerebellum. Friedreich's ataxia is an autosomal recessive disorder. It's caused by a mutation of the frataxin gene on chromosome 9. This gene is necessary for normal mitochondrial function, and the mutation that occurs is an increased number of GAA repeats. This leads to decreased frataxin levels inside of cells. Because frataxin is a mitochondrial protein, there are high levels found in the brain, heart, and pancreas. These are organs that depend heavily on mitochondria. So when there are abnormal frataxin proteins, this leads to mitochondrial dysfunction, principally in these structures listed on the screen here. In the cerebellum video, I discussed the clinical features in more detail, but I'll briefly review them here. Friedreich's ataxia begins in adolescence with progressive symptoms. There is cerebellar and spinal cord degeneration. That's why this is called a hereditary ataxia. Patients often have loss of balance and weakness. This is associated with hypertrophic cardiomyopathy, and that's a high-yield detail that you should remember for the step 1 exam. And in addition, patients typically develop physical deformities, including kyphoscoliosis and foot abnormalities. Our next trinucleotide repeat disorder is Huntington's disease. I discussed this in detail in a video in the neurology section, but I'll briefly review its features here. Huntington's disease is a movement disorder that involves the central nervous system. It's an autosomal dominant disorder that is caused by mutations in the HTT gene, which codes for the protein Huntington. In patients who have the mutation, there is an increased number of CAG repeats, and because CAG codes for glutamine, this is often called a polyglutamine disorder. There are a couple of these other than Huntington's. The others are all very rare, but they are all central nervous system disorders that involve an increased number of CAG repeats. Just like in all of the trinucleotide repeat disorder genes, the HTT gene normally has 10 to 35 repeats found in normal individuals. In individuals with Huntington's disease, there are an increased number of repeats found from 36 to 120. The symptoms result from degeneration in the basal ganglia, specifically the striatum. This can lead to symptoms of chorea. There's also typically dementia. The onset of symptoms is usually in the 30s to 40s, and death usually occurs after 10 to 20 years. Our last trinucleotide repeat disorder is myotonic dystrophy. This is a muscle disorder. It's considered one of the muscular dystrophies, along with Duchenne and Becker muscular dystrophy, and myotonic dystrophy is an autosomal dominant disorder. There are a number of subtypes of myotonic dystrophy. The most common type is called type 1. This is caused by an abnormal DMPK gene on chromosome 19. DMPK stands for dystrophia myotonica protein kinase. The abnormality in the gene is usually a CTG repeat expansion, and this gene codes for a protein called myotonic dystrophy protein kinase. When the CTG expansion is excessive, this leads to an abnormal gene that gets transcribed into MRA but never gets translated, and therefore there is loss of the myotonic dystrophy protein kinase. The less common type is called type 2. This involves a different gene called CNBP. This is much more rare. It's usually a less severe disorder than type 1. And interestingly, this is a CCTG or tetranucleotide repeat disorder. It is not a trinucleotide repeat disorder. In the more common type 1 form of myotonic dystrophy, symptoms begin in adulthood, usually in the 20s or 30s. This is much later than the symptoms that begin in other muscular dystrophies like Duchenne and Becker. There is progressive muscle wasting and weakness, and the reason it is called myotonic is because patients usually exhibit myotonia, which is prolonged muscle contractions. They're often unable to relax their muscles after use. For example, classic symptoms are inability to release the grip or locking of the jaw. The facial muscles are often affected, and this gives patients a characteristic facial appearance caused by muscle weakness and wasting. This is a picture of a man with myotonic dystrophy shown on the screen here. Patients typically have a long and narrowed face and hollowed cheeks. And one thing that's important to remember about myotonic dystrophy is that it's a multi-system disorder that involves many non-muscle systems of the body. Patients with this disorder typically display hypogonadism, cataracts, cardiac arrhythmia, and they often develop frontal balding, just like this man shown in the picture here. The hypogonadism is a primary hypogonadism. The testes release low levels of testosterone. The FSH level is usually elevated. These patients typically have oligospermia and infertility, and they can develop testicular atrophy. In addition, other endocrine systems can be involved, and insulin resistance in particular is common. The heart can be involved in myotonic dystrophy, just like it can be involved in other forms of muscular dystrophy. However, in myotonic dystrophy, it's more often arrhythmias that develop as opposed to heart failure. Patients can develop a first-degree AV block. This is the most common finding. They can also develop bundle branch blocks. They also often develop arrhythmias like atrial flutter and atrial fibrillation. There's a high prevalence of cataracts in patients with myotonic dystrophy. Also, they occur at a younger age. And for this reason, these patients are often referred for regular slit lamp exams to screen their eyes for early development of cataracts. The lungs are often involved and respiratory complications are common. This usually results from weakness and myotonia of the respiratory muscles. This leads to a decreased vital capacity and alveolar hypoventilation, and respiratory failure can occur and can be a mode of death. And then finally, intellectual disability is common in myotonic dystrophy. The severity is worse with a younger age of onset. So for example, individuals who develop myotonic dystrophy in childhood often have severe cognitive impairment throughout their lives. And that concludes our video on trinucleotide repeat disorders.